Okay. Good morning, Frank. Good morning, everyone. Thank you very much for your interest in this panel. I'm really excited to participate in this panel and give you some perspective from me as a physician scientist at the Cleveland Clinic. Frank already introduced myself. I just want to add two more things. I'm not only a scientist, I'm also a physician. I'm an anesthesiologist, so I'm really taking care of my patients. And I think this is a big advantage. I'm not only talking about research, I also implement it in a daily clinical practice. Having this said, disclosure, I do not have any personal financial interest related to this lecture, to this topic, or even with this company. I want everyone to make aware that I'm the principal investigator of an investigator-initiated clinical trial, which is actually funded by Medicines, but I do not receive any penny for myself. It directly goes to my institution. All right. Frank already discussed a little bit the difference between pain and nociception. I want to stress this difference a little bit more because this is fundamental to understand this technology. Just to repeat, Frank already said, but let me repeat, nociception is a kind of the physiological response to a noxious stimulus. And the consequence of nociception is an autonomic and/or behavioral response. The important thing is it's an autonomic response, and you don't have to be awake just to have this nociception response going on in your body. And nociception can, of course, occur without pain. And this is important. It can occur without pain because if you're having a surgery, if you're under general anesthesia, hopefully you will not have any pain because you're asleep. But still, nociception is going on. So in narcotized patients, they do have nociception, but they do not experience any pain. And as the definition of pain, pain is a conscious perception of the unpleasant sensory experience from actual or potential tissue injury. Again, the most important difference, nociception, all of our patients do have a nociceptive response, while our patients during anesthesia hopefully do not have any pain, but it might be different afterwards.
Kurt, can you please turn on your camera so I can see you?
Oh, sure.
Perfect. Oh, and yeah.
Oh, here we go.
That's
All right.
better.
Okay. Good. And as a consequence, I think we have to discuss this strategy. So I just told you that the patient during anesthesia is asleep. This patient does not have any pain. So as a consequence, the intraoperative goal in patients having anesthesia is to control nociception. And most important, nociception per se, you cannot measure that. If this technology works, it would be great. But up till now, beside of this current technology we are going to present today, there is actually no way to directly measure nociception. And it's important to understand, we are treating the adrenergic stress response because in the clinical setting, we are treating changes in hemodynamics, lacrimation, sweating, pupil diameter, and movements. Most of the time, we rely on hemodynamics. We rely on tachycardia. We rely on hypertension. It sounds that easy, but in the real clinical setting, this is the most important challenging part because there are at least 27 reasons why the patients can get tachycardia during a procedure. And on top of it, especially if you're dealing with older sick patients, some of these patients, or maybe a huge majority of the patients, are being on beta blocker. So they will never get tachycardic. In difference, the perioperative goal is the controlling pain. Because suddenly, if the patient is awake after anesthesia in the PACU, the patient is awake, he might have nociception, and he's having pain. So you can talk with the patient. Are you in pain? Yes or no? So now you can treat the pain. And I want to stress that it's not important if you give more or less opioids during anesthesia. I don't think this is the real point. The point is that you have to optimize the analgesic regimen during anesthesia. So you don't give too much. You should not give too less. You should give the right amount of opiates needed for each and every individual patient. And I think we all agree there is one sort of pain extremely difficult to treat. It's not only difficult, maybe it's also dangerous. And this is the so-called breakthrough pain. I guess we all agree, if you're having a patient screaming in pain in the PACU, this is a dangerous patient because suddenly you have to use much more potent opioids. And on top of it, you might need a higher dose of these opioids. And the consequence are sometimes severe side effects. So as a clinician, our goal should be to avoid breakthrough pain in any of our patients and not be forced to actually treating that. So why are we talking about pain? Is it actually common in the clinical setting? Yes, it is. And I think this slide is an eye-opener. If you look on the left side in the inpatient setting, we have to be aware that about half of our patients experience moderate pain. Half of them. But maybe even more bothersome that about a third of our patients experience severe or even extreme pain. Frank already said pain is sometimes really difficult to assess. If you do a skin incision in one patient and you do exactly the same in another patient, you might have extremely difficult values of pain. There is a lot of cultural factors, individual factors involved, but it doesn't matter. It really doesn't matter. The most important thing is your individual patient. If your individual patient in the PACU is complaining of pain, this is serious and we have to take care of it. Does acute pain cause complications? Unfortunately, it does, and there are a huge variety of complications. I just want to list a few of them. First of them, pulmonary complications. This is not really surprising. We all agree that if you are in pain, you might have a shallow breathing, you are not able to take nice deep breath because it's painful, and you're having hyperventilation. And especially after anesthesia, this might be a problem because each and every patient having an intubation anesthesia will have atelectasis. And the combination of hypoventilation in the PACU on the basis on atelectasis will cause hypoxemia and at the end of the day, maybe even an infection, which might be serious. Acute pain also causes change in the gastrointestinal, so especially reduced motility, ileus, a major problem. I just did a large study, a retrospective study on that. Ileus is much more common than we actually believe. Nausea and vomiting, mostly attributed to giving opioids in the PACU. Acute pain also causes some renal complication and an increase of sphincter tone and urinary retention. So this is serious. But even more serious might be cardiovascular complication. This is a large retrospective analysis from my institution, and we were hypothesizing that patients having acute pain after anesthesia on the first 2 postoperative days might have a higher risk of cardiovascular complications. This might not be surprising because each of us, we already experience pain and we know how it feels. You might be stressed. You have a stress response, you might be tachycardic, you might be hypertensive. So all this causes a huge oxygen demand increase in your heart. So for this specific analysis, we were interested, does acute pain cause myocardial injury after non-cardiac surgery? No surprise, it does. On this 10-point Likert scale on the bottom, if you see 0 means no pain, 10 means the maximum pain ever experienced in your life, there is a clear trend. The higher the postoperative pain, the higher the association or the likelihood to have myocardial injury after non-cardiac surgery. Per point increase on the pain score, your odds ratio is about 23%. I think this is significant and we have to be aware of that. But are there any other consequences of acute pain? Yes, there are many. I could now list 20 or 25 or whatever publications. So I just want to summarize a few more aspects of that. First, acute pain increases the functional limitations to our patients. Of course, patients being in pain. This is not the patient who wakes up, walks around, is going down to Starbucks, gets a coffee, walking back. This is the patient who stays in the bed, sometimes screaming in pain. He is not moving at all. So his functional capacity or his functional ability to work on a daily basis is highly, highly limited. There should also be no doubt that acute pain is clearly associated with a poor global recovery. And last but not least, the quality of life is hugely impaired. Quality of life, I personally think this might be even the most important outcome for our individual patients. If you talk with the patient and the patient is not happy with quality of life, if the patient is impaired in his everyday life, he might have a really bad outcome over the time. We are all aware we are living in a pandemic of COVID, but we're also living in an opioid crisis. And I think the hypothesis is clear. If you have a patient who has a lot of acute pain, he might use much more opioids. And by having a lot of acute pain, this is clear association to chronic pain. And by having chronic pain, most of our patients will be chronic opioid users over the time. So maybe this is one of the reasons why we're living in an opioid crisis right now. In this slide, it looks a little bit busy. This summarizes the predictors of chronic pain. Chronic pain is not easily to assess. You cannot say if you do intervention A versus B, you have more or less chronic pain. That would be too easy. There are many, many predictors contributing to chronic pain. I just want to highlight two of them. First, anesthesia and analgesia. It makes a difference how we provide anesthesia. It makes a difference which medications we use. It really makes a difference how we address changes in the hemodynamics, lacrimation, sweating in our individual patient. I don't want to get too much in details because I think you already know what I want to aim for. And last but not least is the pain. The patients being in acute pain is a huge contributor for chronic pain. I know it's usually not that easy to say, but please allow me to say that a little bit in lay words. The more acute pain a patient experiences, the more likely that the patient is having chronic pain. I think this is a fair statement and we should be aware of that. And if you're talking about chronic pain, if you remember one of the first slides, I showed you that acute pain is really common in our patients. But what about chronic pain? Is chronic pain really a problem in our patients' populations? And this most recent or 5-year-old analysis from Montes from Spain clearly indicates chronic pain is a problem. Chronic pain is something we have to deal with. And if you look on the left side, get started with hernia repair. After 4 months, still 13% are having chronic pain. And if you look into the same patient population after 2 years, still 4%. 1 out of 25 patients are having chronic pain. And it's even more in vaginal hysterectomy. It's even higher in abdominal hysterectomy. It might be the highest in patients having a thoracotomy. Think about 4 out of 10 patients having a thoracotomy today will have chronic pain within the next 4 months. 1 out of 5 patients will have chronic pain in 1 year from now, and about 1 out of 8 patients will have chronic pain in 24 months. So chronic pain is a problem. We have to deal with it. So, and having this said, the hypothesis of this new device about this new technology is a consequence of all what I already said. We have to understand we want to treat nociception during anesthesia. And by measuring, understanding nociception, we want to guide and optimize our intraoperative analgesic regimen. So we are not treating adrenergic responses. We want to treat nociception. And by optimization of analgesic regimen, we strongly believe that we will have huge effect beyond the operating room. And one of the first clinical signs that this works would be less acute pain. And I want to stress again, it's not only less acute pain. If you have less acute pain in the PACU, you might also prevent cardiovascular, pulmonary, gastrointestinal, and renal complications. But you might also increase patient satisfaction. You accelerate patient recovery. You might be able to avoid chronic pain. And by avoiding chronic pain, you decrease the opioid consumption. And last but not least, you will help to battle the opioid crisis. One of the large studies Frank mentioned before was a study performed in Europe. I think it was in Netherlands by Albert de Haan. And they were using remifentanil for treatment of intraoperative nociception. Our standard of care, at least at the Cleveland Clinic, and I assume it will be in the huge majority of the hospitals in the United States, is the standard of care for treating pain or nociception is fentanyl. And that's the reason why we need a clinical trial using fentanyl in patients having major abdominal surgery. Major abdominal surgery lasting more than 2 hours. And what we're actually doing, we randomly assign this patient to the nociception guided treatment versus the standard of care. I think we have to be aware, standard of care is really difficult to assess because if you ask 10 individual providers, you might have at least 20 different opinions. Each and every one of us does have strong opinion that this is the right amount of medication A and medication B for this specific patient. All of us, we have strong opinions because we are dealing with these patients on a regular basis every single day. So it's sometimes really difficult to assess standard of care. In this large study, we want to assess the pain scores at 10-minute intervals during the initial 60 minutes of recovery in the post-anesthesia care unit. Again, less pain in the PACU might have huge impact beyond the OR. And I think it was one of my first slides. I stressed out the importance of the so-called breakthrough pain. Breakthrough pain is common and is dangerous and difficult to treat. And as a secondary outcome for this trial, we assess whether or not the pain score at any given time point is above 5 and where we actually need intervention on that. I am not allowed to share more data with you about the ongoing trial. I just can report that we just closed enrollment for the second interim analysis, but I don't know if we are going to close it right away or if it still needs a couple more patients. But please keep your eye open. This study will be published hopefully soon. I already come to my take-home message. I think intraoperative pain management affects postoperative pain. But again, intraoperatively, we are not able to treat pain because there is no pain by definition. We should try to do whatever we can to treat intraoperative nociception. I strongly believe, although I'm aware that we are living in an opioid crisis, giving less opioids is not always better. And I know several colleagues of mine that say, oh, we are just giving less opioids during anesthesia. That's not the 100% right answer to that. Less opioids are not always better. And by intraoperative optimization of the pain management, we hope to have less nociception. By having less nociception, we might have less acute postoperative pain, and ultimately, which is our ultimate goal, have less long-term morbidity and persistent pain in our individual patient population. That's it from me for now. I'm looking forward for the Q&A session.
Thank you. As usual, the experts have a lot to say, and we're a little over time. We have about 6 minutes left, so we're going to get through some of your questions really quickly. Let me start off with the first one relating to pediatric patients. No, null has not been validated in pediatric patients. If you remember that slide where I showed you how null was derived, these are all adult patients. So certainly the null indices need to be recharacterized for pediatrics for a number of reasons. The second question we have, I'm going to give to Kurt, relating to elaborating how the technology is used to assess regional blocks.
Okay, thank you very much. No, we don't know if the nociception level approaches zero in, for example, you said a complete upper extremity block, because we didn't do it so far. But from our clinical experience, when we got the device, we were trying to use that in our clinical practice, and we used it in patients having major abdominal surgeries. And when we gave a tap block, it was really interesting to see. There was a nociception index of 10, 20, whatever it was. And as soon as we start giving the local anesthesia for the tap block, it went down to zero. So at least for the tap block, yes, it does affect the nociception level.
And also in thoracic surgery, the blocks have been verified, the different types of blocks we do in thoracic surgery using the null. So if people found that, there's a couple of case reports relating to that, and we'll put those online for you to check out. Kurt, did you want to handle a chronic pain and addiction question?
So yes, I'm happy to respond to that. So I think the problem is that my clinical experience is limited to a couple hundred patients we did so far. And of course, we are dealing with some patients being addicted to any kind of medications. It does help to optimize opioids. Also, we had to give sometimes more opioids, but at least from my personal perspective, and there is no study about that, it does really help. So it really looks like that it's also helping with these patients specifically.
So certainly in opioid tolerant patients, I think the question here is in chronic pain conditions, as in clinic chronic pain conditions. And no, that's not, remember, those are awake patients, we hope, typically, and that is not being evaluated. And addictions, no, it has not been evaluated. What's interesting is that the large domain of applications that people can think of in terms of an objective pain monitor, and that's really, really good. Want to mention, we cut short the Q&A with Dr. Gann. One of the questions I asked him specifically, and please go online to see his response, but I'm going to paraphrase it. People say to me, why do I need a nociception monitor? I'm practicing multimodal analgesia in the optimal ERAS program. And his answer was basically, you still, a nociception monitor has a lot of advantages for all the reasons that he's described. So that's not a, that doesn't, just because you have multimodal analgesia and ERAS doesn't mean you don't need a better objective monitor. As Kurt said, the monitor is not, you don't sell this monitor to your pharmacist or your corner suite, to the C-suite, by saying we're going to use fewer opioids. It's about optimizing opioids. It's not about using less drug. Some patients use less, some patients use more, but you optimize it. And for all the reasons that Kurt explained, why acute pain causes so many problems, that's really where the value is. You want to comment on that, Kurt?
Yeah, no, you said actually what, yeah, absolutely. There's nothing to add.
So you don't think if you're a multimodal site, which all of us should be, that doesn't change the equation?
Yeah, I think, the multimodal approach is a really important one. But it's, at least in my personal perspective, the null really helps to give the right amount during anesthesia, during the procedure. But if it's for the long run, specific for this patient population, I cannot really comment on that yet.
Okay. Anne asked if the blood pressure cuff is on too high, does the null generate an output? I imagine it would. We don't have a specific case report relating to that. And and then the sensitivity to use of sympatholytics. We got 2 minutes. Kurt, tell them about what happens to the null when you give ephedrine or sympatholytics. And that's a great question for Iman, because obviously there's an impact.
Yeah, absolutely. So the technology might be to a certain amount be driven by tachycardia. And whenever you give any medications like atropine or the muscle paralytics reversal, patients getting tachycardia. And initially you see then a huge increase in the null, which is mostly driven by tachycardia. So in this specific setting, I would strongly suggest wait a little bit, wait 2, 3, 4 minutes, because the sensitivity is really high. the null monitor responds right away within a couple of seconds. Before the patient is getting tachycardic on the monitor, you already see the increase on the null. That's really interesting. Yeah. But specific in this clinical setting, if you give atropine, for example, I would not, let's say, trust the null right away. I would wait for a couple of more minutes, just wait. And usually if the effect is mostly triggered by the new onset of tachycardia, it will go away over the next 3-4 minutes. So the sensitivity in this medication is really high. It's great. It really works, at least.
So that's great. If you understand how the null works, what its input signals are, you understand that you may have a spike when you give a ephedrine or a sympathetic, and that's key, and that means it's working. Listen, folks, we're out of time. We'd love to have a longer Q&A session. We'll do a little better, speaking a little faster next time, but we appreciate your interest and your time and getting up early, and enjoy the rest of the day and your meeting, and all the best. Thank you, folks, and thank you, Kurt. Great for having you on.